Good morning, everybody. I'd like to welcome you to Vision Health Canada's first conference. Thank you. I'd like to, on your program, you'll see here that Michael Balajan was supposed to be our moderator for today. Michael has organized almost everything associated with this conference. And unfortunately, last night, Mike got very excited by being a new grandfather. And he and his wife bought a little kit to build a crib for their kids, for the new grandkid. And he had it in a box in his bedroom, and he tripped over it around midnight last night and has broken his hip. So anyway, there's a good side and a bad side to that story. The good side is the grandkid will always remember it. But the bad side is you got me for today. To start with, I'd like to read a message that Mike sent us. And he said, "Good morning, everyone. Thank you for joining us today. I'm so sorry I can't be with you in person. Sometimes life has unexpected plans, and this is one of those moments. On behalf of Vision Health Canada, I want to sincerely thank the more than 420 attendees joining us in person and virtually at today's conference. Your presence is a meaningful recognition of the work that we do and of the trust and confidence you place in us as we advance vision health across Canada. We've planned an engaging and thoughtful program, and I'm grateful to the many speakers and panelists who will be sharing their expertise and lived experience with you today. I wish I could be there with you, but I hope you have a wonderful and productive conference." From Michael. With that, I'd like to move on to the reconciliation. I have the privilege of living and working on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee, in a place that's now home to many diverse First Nations, Inuit, and Métis peoples. I recognize and deeply appreciate their historic connection to this land and the contributions Indigenous peoples have made in shaping and strengthening this community. I am grateful for the opportunity to honor the promise and challenge of truth and reconciliation, and I acknowledge that meaningful reconciliation is a shared responsibility. And with that, I would like to introduce our Chairman of Vision Health Canada. Ian White was the past chair of the Toronto CCB Visionaries chapter. He has had a long career associated with vision organizations in advocacy on behalf of people living with blindness and partial sight. And we are really privileged to have him as chair of the board of Vision Health Canada and our introductory speaker. Ian.
Thank you. Thanks very much. Thanks, Keith. It's an absolute privilege and an honor to be here today. Thank you all for coming to our sort of inaugural conference. Keith and Mike and a number of others in the background have been doing this kind of work for a number of years now. We previously were working under the Canadian Council of the Blind's banner. We've decided to move out on our own, and I am absolutely thrilled to have you all here for our first major conference. What I'd like to do this morning is just very briefly talk a little bit about Vision Health Canada as an organization. We're a brand new not-for-profit. And I want to talk a little bit about sort of where we're focusing and how we're seeing ourselves sort of positioned in the landscape. So one of the things that I think is really important from our standpoint is dealing with people as people, talking about health and the whole person. So there's a really interesting sort of range of definitions that are possible for the word health. And I just want to sort of go through and clarify how we see vision health as a sort of topic of focus. So what do we mean by health? The word health is often interpreted to mean physical health. That is the absence of illness. The knower of all things, Wikipedia, offers a definition as health is the physical and emotional well-being, especially that associated with normal functioning of the body, absence of disease or pain, and absence of injury. And if you notice the main components of that definition, the normal functioning of the body, physical or mental well-being, negatively defined as the absence of disease, pain, or injury. It really is a definition that's focused on the body as object, on the biology and the disruption of the normal functioning of that biology. So this is a medical definition of health that sees the body as a series of interconnected systems that have a normal state and a state which can deviate from the normal. It can malfunction or become broken. So in order to regain health in this kind of context, medical professionals will intervene or treat to reestablish normal functioning. This definition, while important, is limited from our perspective. It expresses health relative to a human being only as a medical patient and really prescribes discussions of health to the medical or healthcare journey. It's concerned with and limited to the normal physical functioning of the body or parts of the body. And it disregards aspects of psychology aside from sort of clinical definitions of mental illness. And it explicitly does not deal with a person's social context. So in a lot of ways, it does not necessarily concern itself with the overall thriving of that individual. And I think that's a really important distinction. One of the things that that has been really important to our journey and our definition is this idea of promoting total human thriving. So taking the idea of health beyond a strictly medical definition. So why is the broader definition of health of interest or important? I want to refer to the 2021 Cost of Vision Loss and Blindness in Canada study. And in that study, it was essentially made clear that the $33 billion cost to the Canadian economy on an annual basis was comprised of two major areas. There are direct healthcare costs, the costs of diagnosis, treatment, interventions, rehabilitation, et cetera. And then there are social impact costs. So those are the costs of loss of productivity. And what's interesting about the way the split runs down is that it's actually 53% of the cost, the total cost to the economy, that is the social impact side of that equation. Healthcare comprises 47% of that total. So if we're going to address all of those costs, if we're going to actually make a serious dent in that $33 billion cost to the Canadian economy, one of the things that's really vital is that we develop more effective policies and strategies to offset these costs, both the medical costs and the negative social impacts. We have to consider the whole person and that person's social context, and not merely just that individual as a medical patient. We need to adopt a definition of health that incorporates the social impacts of blindness. So we need to look beyond the patient's healthcare journey to all of the factors that limit their thriving. So the word health in our organization's name, Vision Health Canada, it refers to a state of health for the whole person, including their physical, mental, and social contexts. Not that prevention of vision loss is not important, it absolutely is, and this is where healthcare plays an absolutely vital role. The cost of vision loss study also indicates that 75% of vision loss is preventable if the right combination of diagnosis, treatment, drug approvals, new therapies, et cetera, is all put in place and brought to bear. So the role of medical intervention to prevent vision loss is absolutely vital to reduce vision loss as much as possible. But no matter how effective these strategies are, there will always be hundreds of thousands of Canadians whose sight loss cannot be prevented. For them, we need better, more robust, more effective supports to help offset the social costs that come with loss of sight, and to make sure that we're addressing all of the factors that impact overall health. We must broaden the definition of health to include the whole person. The word health in VHC's name, then, takes its definition from Canada's federal government and the WHO, using a concept called the population health approach. And according to the WHO, quote, a state of complete physical, mental, and social well-being cannot merely be the absence of disease or infirmity, end quote. And, quote, social well-being is an important aspect of this definition that may not always occur to us in thinking about our health, end quote. The Ottawa Charter for Health Promotion affirms social, economic, and environmental aspects of health. This important document states that in order to be healthy, quote, an individual or organization must be able to identify and realize aspirations, to satisfy needs, and to change or cope with the environment. In this way, health is seen as a resource or an asset that helps us lead our everyday lives. Health is seen as a positive concept that recognizes and emphasizes social embeddedness and the importance of our networks of social and personal resources, in addition to the physical capacities that we have. So what are the things that affect health? There are many broad factors that affect health in our life. Again, according to the population health approach, these factors include what are called social determinants of health. And a list of these are income and social status, social support networks, education and literacy, employment and working conditions, social environments, physical environments, personal health practices and coping skills, healthy child development, biology and genetic endowment, health services, gender, culture. And it's really interesting to note in that whole list, there are only 2 or 3 of those indicators of overall health that are directly or even indirectly connected to our biology. The vast majority of them are, in fact, social factors. Yet all of them contribute to an overall state of good health. It's the interrelatedness and changes in these determinants that makes the health of individuals or groups a complex combination of factors, and each person's experience of health can differ widely and vary across a lifetime. So when faced with challenges, problems on the job, relationship troubles, loss of a loved one, good health provides us with the physical and emotional resilience that we need to cope with difficult times, to regain our balance and live life as fully as we possibly can. When considering the word health, it's this broader, socially oriented definition of health that we want to incorporate. In our view, vision health affects the whole person and the entirety of their physical, mental, and social engagement in Canadian society. It certainly includes all aspects of visual health care, public awareness, diagnosis, treatment, etc., the prevention and treatment of eye disease, but it extends well beyond that into a whole range of socially interconnected interactions that we have throughout our life. To those whose vision loss is not treatable or preventable, and to the many barriers that they face, it's important for us to stay focused on the entire human experience of vision loss in order to adequately support and assist and reintegrate people with profound vision loss into Canadian society and remediate a lot of those social impact costs that are such a profound part of the overall cost to the Canadian economy. So I want to just introduce Vision Health Canada as an organization. As I mentioned, we're a recently formed not-for-profit, and our focus is primarily on the sharing of information through targeted research and through advocacy work. So how do we incorporate this broader definition of health into what we do? What do we mean by one voice, clear focus, and collective action, which is sort of the tagline that we've decided to run with? So let's break it down. One voice. The directors of VHC believe in building coalitions across the vision health landscape, partnering with stakeholder groups in all areas of advocacy, and that's advocacy for better vision health. By aligning ourselves with vision health partners, established organizations, foundations, and professional associations, together we can build a collective, formidable presence, furthering efforts to encourage the prevention of vision loss wherever possible, and to drive more effective policy decision-making for those with blindness and partial sight. But most importantly, we seek to raise the voices of the 8 million Canadians living with a condition that could lead to vision loss, and the 1.2 million people who are currently living with blindness or partial sight right now. Clear focus. At VHC, we believe that effective policy making can only happen with access to solid evidence-based research. It's imperative, therefore, that first, solid eye health research be undertaken to identify all possible avenues for the prevention of vision loss wherever possible, so that early detection and aggressive treatment with the best available drugs and treatments catch eye disease before damage is done. And for those whose sight loss cannot be arrested or prevented, two, that research be conducted to fill a number of profound gaps in our understanding, to delineate the circumstances and the barriers faced by people with vision loss, and to ensure that access to robust, equitable, and affordable habilitation and rehabilitation supports and services are available to help blind and partially sighted Canadians build the skills they need to fully integrate in Canadian society. This includes ongoing access to upskilling and social supports, addressing broader social issues like poverty, employment, stigma, public education, affordable access to the latest assistive technologies, and equitable access to all aspects of Canadian life. Collective action. Together with our partners across the vision health community, we can share information and resources. We can initiate and disseminate a wide range of vision health research, especially research that promotes prevention and addresses the social impacts of vision loss. And we can help define issues that matter to policy decision makers, to organizations working with visually impaired Canadians, and to those Canadians living with blindness and partial sight. With one unified voice, we can speak. With clear focus, we can identify the issues that matter. And with collective action, we can work with our partners to move the needle, to prevent sight loss wherever possible, and together, we can advocate to more adequately support the millions of Canadians who are blind and partially sighted. And we can drive the kind of evidence-based change that can promote full human thriving for all of us. In closing, I'd like to recognize the founding directors of Vision Health Canada, myself as chair, Michael Balarjan, who is our CEO and president, Keith Gordon, Dr. Keith Gordon, who is our chief of research, Jim Hall, who is our CFO, Luna Bengio, she is our accessibility and inclusion officer, and Jim Sanders, who is director at large. I would like to recognize those folks. If any of those directors are in the room, could they stand up and just accept a round of applause from the crowd, please? Thanks so much. We're going to move on to the next phase of our conference now, and that's going to be a panel contribution. There is someone in the audience, Marilyn Broughton, if she could stand, please. And I will turn it over to Marilyn. I just wanted to say thank you again for coming. It is an absolute pleasure to have you here. Please enjoy the conference.
Marilyn Broughton is a patient with geographic atrophy, and Marilyn's going to tell us about her experience as a patient, some of the things she went through in getting diagnosed, and what she's experiencing today. And we really appreciate your coming in here and telling us about it. The next section of the meeting is going to be about geographic atrophy, about AMD in general, and geographic atrophy specifically. So thank you very much, Marilyn.
Thank you all. It's really a wonderful experience to be here with all these talented people and find out what we can do to improve things. I have the macular degeneration, and I find one way in which it affects me, I keep getting little spots that I see. It reminds me of licorice all sorts, the flat kind that have the little beads on them. And that's what I have often coming across, going across my vision area. And they don't bump into each other, but they just float around, and it's a little distracting at times. And at nighttime, I find if I'm in bed, the room's dark, but there's some light coming through the drapes, that sometimes I get black spots that go across from bottom left to the top right. And so I have these distractions sometimes. I have been treated by Dr. Popovic, and I've had a couple of sessions with having injections in the eyes. I find that it helps for a couple of days, and then we're back to this problem again. But anyhow, I'm hopeful that things will improve, and I will gain more of my sight back. I do, in my right eye, I do have vision loss in the center if I'm looking at something, and then if I cover my left eye, look with the right, I only see peripheral. I don't see the center. But doesn't prevent me from seeing other things. So that's my experience, and others will be sharing with theirs too. So thank you very much.
Thank you very much, Marilyn. And next section, I would like to introduce you to Dr. Brendan Tao. Dr. Tao is an ophthalmology resident at the University of Toronto, and he's going to be talking to us about the relationship between AMD, age-related macular degeneration, and geographic atrophy. Dr. Tao, thank you.
Okay, hi, I'm Dr. Brendan Tao. I'm one of the residents here at the University of Toronto in the Department of Ophthalmology and Vision Sciences. I have no disclosures to share with you today, and I'm very excited to be able to share more about what age-related macular degeneration is, the spectrum of the disease that it encapsulates, and we'll dive in a little bit into what geographic atrophy is, as well as one slice of what AMD is. So I'll bring you for a bit of a ride here. We're going to start off with a primer on ocular anatomy, so we're all on the same page. A short discussion as well on the tools that we have in our repertoire to investigate for AMD. And finally, we'll talk to you a little bit about AMD and how geographic atrophy fits into that puzzle. So a little bit about the eye here. I think it's without a question that the eye is quite complex. In fact, I've dedicated my 5-year residency to learning all about these two spheres in our head. And despite all that complexity, however, there is a lot of elegance to the structure. And the way that I really like to think of it is it's 3 layers, almost like a gobstopper for those who have a sweet tooth. The outer layer is this fibrous protective layer, the whites of our eyes, that's called the sclera. And that helps protect the more precious structures on the inside. There's also the cornea on the very front, which is like the window through which we see the world. In the middle layer, there's what's called the uvea. It's a very bloody, muscular layer, things like the iris, the coronary, the ciliary body, as well as the choroid. These are all structures that get a lot of blood supply and provide nutrition to the rest of the eye. But I would say the crown jewel of the eye is the retina, and that's the reason for which we're all here today. The retina is very much a structure that helps us to see the world as it was. So a little bit more about the retina. The retina is like the camera of your eye. It's the digital sensor. And so when your eye sees the world ahead of you and that light comes and touches onto the retina, it's very much like a digital sensor, and it sends that image to your brain where it's interpreted. So I've shown you a picture here on your right. Is a picture of a normal eye. This is actually when the ophthalmologist puts those eye drops in your eye and the world gets very bright and we shine more light into your eye with the lens. This is actually what we see in what would be a normal eye here. And so you can see what is the optic disc. And the optic disc is like structure further on the right. It's where the actual neurons from the brain project into the eye, and it spreads out like wallpaper onto the back surface of the eye. And that's where all the light goes in, and that's where the detectors are. Now, with relevance to this talk, I'll point your attention to the macula. The macula is the area where there's the most receptors for light. It's like the sweet spot where you are able to see color, fine details. When you read a textbook or using your eyes to look at the very screen you are right now, you're using your macula. At the very center of the macula is the fovea. The fovea is even more of a sweet spot, exactly the most highest acuity vision possible. Goes right to the fovea. Okay, so now for some of the tools that we use. Now, when people say they see 20/20, 20/30, 20/40, what do they mean? They're really talking about how well they see on the Snellen chart. And in that Snellen chart is how we are able to document vision. Every time you come to the office, you take one of these measurements, and that kind of helps us to tell, where are we progressing with your vision. So when someone says they see 20/30, for example, what do they mean? Well, they mean that what you could see at 20 feet away, that smallest line, is the same line that someone of average vision would be able to see, let's say, at 30 feet. So as the number on the bottom goes higher, 20/30, 20/40, 20/50, the poorer your vision is. And there are real complications for this. Like if you see less than 20/50 in one eye, you may not be able to drive. And legal blindness starts in the neighborhood of 2200 to 2400. There are some more tricks up our sleeve. We have the indirect ophthalmoscope. So that lets us get a nice bird's eye view of the back of the eye, just like you see here in the middle photo. We wear a funny hat, the one that you see on your left, and also a ton of light, so you can't see us wear that hat. There's also the direct ophthalmoscope, the slit lamp on the very far right. That's the image there. It helps us to get very small microscopic views into the retina. When the bird's eye view doesn't give us enough detail, we need to magnify and see what's going on, we use the slit lamp, and both of which are important to our arsenal of investigations. But what happens when the pathology is so small that it can't possibly be seen with the human eye? Where do we go there? And certainly what we are very thankful to have is what's called optical coherence tomography. It's like taking a picture of the eye. It's like an ultrasound of the eye, but using light. And that lets us to see on the order of microns. Super, super, super small. And so you can see here on your right is what a normal retina looks like. It's a nice kind of multi-layered cake, like a tiramisu, some would say. And on the very left, is obviously maybe a tiramisu that went a little bit wrong. You can see that there's some fluid underneath the retina, that black space. There's just stuff that doesn't quite look right with this retina, and that helps us to see it. Sometimes, this on a clinical exam, when I look with my eye, may just look like a tiny spot, but there's more to that spot, as OCT would show us. Okay, so I promised I'd tell you about AMD, and so here we go. Age-related macular degeneration is an incurable, at present, type of acquired deterioration of the retina that causes significant visual impairment in the center of your vision. The opposite of that might be like glaucoma, for example, where you start to lose the periphery. So AMD really is a disease of the central vision. And this is not an uncommon disease. Over 2.5 million Canadians have AMD. It's responsible for between 6 to 9% of global blindness. And every year in Canada alone, our GDP is costed by $2.5 billion. So that's certainly no small chunk of change. Now, what does it look like? It's hard to say, but I've given you here an example here. On the top series of photos, this is what normal vision may be. And with someone with AMD, this is what they would see on the bottom series of images. So again, central visual blacking out. Okay, so when I look in the eye, what does it look like? Well, I've given here an example on the left, which is a normal eye. And when you look on the right, you can see there's like these deposits, the hallmark of AMD. For over 100 years, doctors have seen what's called drusen, these yellow deposits that build up in the center of the macula. And these deposits are what is thought to drive the disease of AMD. Now, there's a couple risk factors, advancing age, smoking history, genetics, blood pressure, other things, looking at the sun for too long. These are all things that can contribute to AMD. So I'll walk you through the stages here. On your very left is an eye that has no drusen. It's a healthy eye, no treatment needed. In some people, they might get some drusen, just a few spots here and there around the macula. And for many people at that stage, when they come to the office, we'd recommend they take vitamins. You can get them at the drugstore. They're called AREDS, AREDS 2 vitamins. They have a special cocktail of vitamins that help to reduce the inflammation in the eye and helps to slow the progression. Some of those patients will go on still nonetheless. They develop a bit more drusen. And when we get to the more severe end of the stage, we get to a crossroads. And there's two main, I would say, pictures that one can develop with severe AMD. There's geographic atrophy, which we'll definitely talk about a bit more later. And there's also what's called wet or neovascular AMD. So we'll briefly touch on those two. When you get to these stages, that's usually when we're talking about intravitreal injections or injections of medications into the eye to treat these diseases. So really briefly on wet AMD. So wet AMD is AMD with inflammation driven by the growth of abnormal blood vessels in the eye. And that sounds great. More blood vessels is a good thing, right? Unfortunately, that's what I thought when I was a medical student. When I have read more into this, these blood vessels grow in aberrant ways. They're very fragile. They can break, they can bleed, they can pull on the retina, causing a detachment. They can cause leakage beneath the retina, causing fluid. So these are very harmful vessels. And so you can see here in the OCT in the top right, there's fluid in the eye. It warps the curvature of the fovea. And so if you ask somebody to look at a grid, they'll actually see what is on your top left here. So not only is there the central vision loss, but there's a bit of waviness and distortion of the image itself. Now, this is a patient who saw 2100 when they came, and they had a couple of injections of what's called anti-vascular endothelial growth factor, anti-VEGF. And within 3 months, they had, you can see in the bottom right here, a big reduction in the amount of fluid, and their vision actually improved to 20/50, so over a 2 times improvement. And you can see here that some of the waviness when they looked at the grid was a bit reduced as well. Okay, so now there's the other side of geographic atrophy. So, when we go back here, we didn't go down the neovascular route. We're instead going down the geographic atrophy route, which is another way that AMD can progress. And so what geographic atrophy truly is when some of the neurons in the macula start to die off and it starts to thin. And this as well is a significant condition. Over 8 million people have GA worldwide. About 1 in 5 patients with AMD will go on to develop geographic atrophy. And some of the risk factors are quite similar to those with AMD in the first place. Okay, so geographic atrophy, just to kind of show you exactly how it evolves. On the very left, we have a healthy eye. There's no drusen. The fundus looks perfectly good to me. The thickness of the retinal layers is within average. And when a patient develops AMD, like as we discussed, they get these hallmark yellow drusen that build up in the macula. But the retina is not quite thinning just as yet. The cells are still alive, but they're being irritated by the deposits of this drusen. But when we get to the very severe stage of geographic atrophy, that's when the inflammation and all the drusens start to cause a little bit too much trouble for the retina. And some of the retinal cells start to die off. And when they die off, it sort of thins, and it gets thinner. We can actually see that. And actually, it gets to the point, if you kind of see where my cursor is, maybe you don't see my cursor, but you look at the very bottom right photo of the fundus, you can see there's what looks like a patch of atrophy. It's quite visible and manifest to the naked eye, and some would say it looks like a continent on the globe, hence the name geographic atrophy. Okay, so what causes geographic atrophy? So the scientists have been at it for quite a while now, and I can tell you that there's no single cause. And so the exact mechanisms on geographic atrophy and how it comes to fruition is not exactly fully understood. That being said, even as a medical student and going through medical school, there's been a whirlwind of advances just within the last few years alone. One of which is very exciting is the role of the complement system in geographic atrophy. The complement system, it's not a complement, it's actually more of a detriment. The complement is these proteins which are incredibly inflammatory. In fact, they're actually used to help fight off the bugs. You know, like when you get sick, they're one of those first responders. But unfortunately, they are inappropriately activated in the eye. They cause inflammation. Scientists have shown that when there's drusen, and they take the drusen and they inspect it under the microscope, they actually do find complement proteins associated with that drusen. And these drusen are just causing inflammation in the macula, and that, in some ways, thought to progress geographic atrophy. I'll point your attention to those two red squares. It was a very complex schematic for me to memorize, but for you, what I want you to know is two things here, C3 and C5. These are two proteins in the complement pathway that are meant to be targeted by these drugs, which have been approved within probably the last 2 or 3 years, and so they're targeted to these specific parts of the pathway. So, as a brief primer, currently there's no cure, and by cure I mean that there's something that will reverse it or stop the process altogether, but there are treatments. So we can slow the progression of this disease with intravitreal injections of complement inhibitors. The names are a bit of a mouthful: pegcetacoplan, advenoacetylcaptad, PEGL. These target C3 and C5, and sometimes they would be administered up to maybe once every month for patients who are more advanced. In the time being, while we do await, hopefully, a cure to come someday, patients can always benefit from visual rehabilitation. The world is, as you can imagine, is very different for patients with geographic atrophy. Losing the center of vision, it makes it difficult to read, to recognize faces, to drive. These are not small things. And so having rehabilitation with a trained specialist can go a long way in helping somebody to make do with what they do have at the present. Now, one important thing I want to point out here is that when I go back to this, I said we can go down two pathways, geographic atrophy or neovascular AMD. But I really want to drive home the point here that these two are not mutually exclusive. You could have one and or the other. And so it's so important that patients get treatment for this. And if, let's say, you have geographic atrophy, you're getting the drugs that target the complement, and the doctor looks in your eye and they see blood vessels, well, now we're also talking wet AMD as well, and you might need another injection to treat that as well, okay? And so overall, geographic atrophy is on the more severe end of the spectrum of AMD, but we're living in a very, very exciting time right now where there are just new treatments that are coming off the press. As we speak, there are trials that are going on for these as well. And so, you can best believe I'm so excited to read these scientific articles as they come out, and we all talk about them in the back rooms of the doctor's offices at the end of the day. Okay, so that brings me to a close. Hopefully that was a nice segue into introducing more about the eye and a primer on AMD and where geographic atrophy fits within that spectrum. If time allows, I'll be very happy to take any questions, but I really appreciate your attention to my talk this morning. Thank you.
Problem, and there's nothing, it seems, that can be done because there's no research that I know of. That's what my doctors say, just live with it. And my eyes, of course, are getting worse and worse. So I wonder, why is that myopic degeneration, which affects the macula very badly, why isn't there anything to help, that?
Sure. From what I understand about myopic degeneration, it's driven by myopia or nearsightedness. For those that, like myself, that use computers a lot, some of us, quite commonly do have a bit of myopia. For example, my vision is maybe within -1, 2, 3, 4, or 5. People always talk about, I'm +4, when they get to those reader glasses. But oftentimes when you're nearsighted, you might be -3, -4, -5. And so when that happens, the eye elongates. And when the eye elongates, it causes stretching and tension of that tissue of the eye. You only have so much eye. And if you stretch it out like some Play-Doh, the eye gets kind of thinned out. And so, right now there's a lot of treatments, mostly in children when this starts, trying to figure out what causes myopia. Nobody's quite sure yet. And the treatments for that, are hard to come up with at present because we don't know the underlying cause. Within my lifetime, and somewhat it's a bit too late for me actually even, they've been starting to realize now that sunlight exposure as a child actually helps with slowing myopia. But even then, that's not the full picture. So there's no drug that has been identified yet that can readily slow the progression of myopia in some patients. And certainly when you get to myopic degeneration, you're talking about refractions of over -10, -15, really, really high myopia. And so, the anti-VEGF drugs could be useful, when the eye elongates too much and there is inflammation of the vessels that does happen. So that's one treatment that could be used in that specific setting. Okay.
Just to follow up to that, to what you were saying. Thank you. Yeah, no, I was just curious. Like you said, we don't know the causes yet for myopia. Like for parents with kids, with the screen, the whole social, right? How much is screen time and just being just right on it for so long compared to genetics, innate versus environment? Like, what is the research showing with that?
Really briefly, there's not. Screen time is, I think, a component. There's certainly an aspect of strain, but my understanding is that it's not as significant as we all like to stereotypically think about. Mostly, my understanding is one of the biggest factors is of course genetics, but also your exposure to sunlight. I would say those are some of the two bigger hypotheses right now, and screen time is maybe one of the smaller ones.
Thank you.
Thank you.
Thank you very much, Dr. Tal. There is a question online. I'm going to hold the questions. I think some of the answers may become apparent after Dr. Popovic's talk. And I'd like to move ahead and introduce Dr. Marko Popovic. Dr. Marko Popovic is a retinal surgeon, a retina specialist, and he's assistant professor at the Department of Ophthalmology and Vision Sciences at the University of Toronto. Dr. Popovic, thank you very much for being here.
I'm truly honored to be here and just witness the collective patients in our clinics, residents and trainees, doctors, industry partners, other vision health stakeholders. Like, it's truly remarkable to see this group of individuals all come together in a symposium like this. And I really want to thank Vision Health Canada, Keith Gordon, Michael Belarjan, Jim Hall, everyone that works tirelessly behind the scenes to make an event like this successful. And so thank you so much for all the incredible work that you've done, and I look forward to many events like this in the future. So my talk today is on the topic of geographic atrophy, which is, as Brendan was saying, it's kind of one variant of an aggressive form of macular degeneration. And to be honest with you, if I gave this talk 5 or 10 years ago, there wouldn't be actually very much for me to say, because this has somewhat been kind of a forgotten cousin of macular degeneration. The other form, the neovascular or the wet macular degeneration, has received much more attention because we have all these effective new therapies, the anti-VEGF drugs, that have really revolutionized our care for patients with the condition. But geographic atrophy, unfortunately, has been a condition that has not received as much attention until much more recently. So I hope to go into kind of some of the new advances in the field of geographic atrophy and some of the emerging treatments that may be realizable in the near future. So I won't go over, an entire background, because I think Brendan summarized beautifully about age-related macular degeneration. We know that it's the most common cause of vision loss in the developed world in those age 50 and older, and different risk factors obviously include increased age, but also, smoking, blood pressure, obesity, low levels of physical activity, various other factors, including family history, that play a role in this condition. And I think Brendan, demonstrated a similar slide, just looking at how how we look at the retina. This is a copy of a normal retina where you see here the optic disc, which is the cable that connects the eye to the brain. And then beside it is this area called the macula, and the center part of the macula is the fovea. This is all, responsible for your very fine color vision, and fine visual acuity that you use for most of your visual needs during the day. And so this central part of the retina, termed the macula, is really where this condition of age-related macular degeneration happens. And so this is an example of a patient with a more early form of macular degeneration that has not progressed into neovascular or wet AMD or geographic atrophy. So this is just characterized by the presence of drusen, those small little lipid and protein deposits that Brendan summarized so nicely. And so again, a slide summarizing, the progression from a normal retina to the development of drusen, so the early form of macular degeneration. And then it can really branch off into one of two pathways, which we've already discussed about, either geographic atrophy, where there's actually loss of tissue and loss of photoreceptors, or the wet form of the macular degeneration, where there's new blood vessels that form and cause leakage and bleeding and complications as a result of that. This is an example of an image. This is called a fundus autofluorescence image, an image that we commonly use in the clinic to assess the progression of these geographic atrophy lesions over time. And so you could see in this patient who has multiple areas of discrete geographic atrophy, they're those kind of very dark little spots that are kind of innumerable around the center of the fovea. You see over time, by year 3 and year 5, how they grow in size. And so this is an example of an imaging modality that we use in clinic regularly to assess the progression of these geographic atrophy lesions over time. This is an example of a patient where you see in the dead center, their fovea has not yet been affected by the geographic atrophy lesion. So this is a patient who may still retain fairly reasonable vision, but as you see, as those lesions continue to grow over time, they may lose significant vision if their fovea becomes involved, and I'll show you pictures of that as well. So this is another now color photo of the retina, where you see the geographic atrophy lesion, which envelops and circles the fovea. But in this case, that fovea, the center part in this patient, is still maintained. So the patient is still able to retain fairly reasonable vision. They might, for example, complain of loss of the visual field in a part of the vision that's outside of the dead center, but in terms of their general visual function, they may be able to retain reasonable visual function. So that's now in contrast to when geographic atrophy, the condition is advanced and it starts to envelop the fovea. So these are other different imaging modalities that we can use in the clinic to showcase how this patch of geographic atrophy has now gone over the center part of the retina, over the fovea, and this patient is likely to have very poor central vision and poor visual function as a result. And so just tying it back to the patient perspective, because that's something, within the context of this forum that is tremendously important, and I'm so honored to have some of our patients here today to, share some of their stories and experiences with the disease. What are the functional implications? Well, different patients really report different things, and you could see in the, in the normal image on the bottom left, as the image is supposed to be interpreted, a few different, depending on the stage of disease and what disease it is, a few different manifestations can happen. So there could be a darkening or a loss of the visual field in the dead center, where you see a black area in the dead center, as you see in the top left. The colors themselves can be kind of more washed out, as you see in the top right. Like straight lines can start to appear more wavy, as you see in the bottom image, or there can be a general perception that the vision is more dim than the patient is used to, as you see on the bottom right. So these are all, depending on the exact disease, these are all different possible manifestations that can happen from the patient's perspective. And so that's, in a quick way, just to summarize macular degeneration, the wet form and the dry form, and now geographic atrophy. What I'd really like to focus on today in a little bit more detail is some of these new emerging treatments for geographic atrophy, which are novel and have really the potential to change our clinical practice. I'll start off at a very foundational level to say, what is it, if someone presents with us with geographic atrophy, what is it that we do in the clinic very practically? So patients with macular degeneration, one of the things that we tell them to do is to use what's called an Amsler grid. And so you see an image of this represented here, which is basically a checkerboard grid with straight lines. Now, those lines can start becoming distorted with the progression of this disease. And so we ask patients at home, they can monitor this grid. They could put it on their fridge or wherever in their home and periodically monitor the Amsler grid to see whether those distortions evolve over time. And that's really a nice kind of screening test that allows us, if the lines are becoming more distorted over time, it allows us to, for the patient to call into clinic, to be rebooked for an appointment, to see if there's been any anatomic or structural progression of their disease. Different lifestyle remedies, obviously just eating well, eating a well-balanced diet. Leafy green vegetables are very important. Protecting the eyes from sunlight is another very, very important thing. Patients who are smokers, we do advise them to stop smoking because all of these things really play a role in the progression of this condition. And then there are, of course, the AREDS 2 vitamins. So you may see different brand names, Preservision or Vitalux. These are common vitamins given to patients who have the earlier form of macular degeneration, the dry form with those little drusen yellow deposits, which is very good and has robust research that has shown that the condition progresses less frequently to the more advanced form if these vitamins are used. And then, of course, I won't go into a lot of detail about the wet form of macular degeneration, but this is, over the last 10 or 15 years, really been a huge paradigm shift in our clinic, taking something which has been a very poorly treatable condition into something that is much more readily managed with the use of these injections that are delivered into the eye of a medication called the anti-VEGF medication to reduce leakage, bleeding in patients who have these new blood vessels that are growing from the wet form of macular degeneration. And I won't go into the whole history of everything that's happened in the field of wet macular degeneration, but more to give you a summary to show, over the last 20 or so years, there's been a tremendous amount of innovation and advances. Many new companies coming up with new products, showing well-designed research on new agents. The kind of more recent agents that we have an even longer lifespan or durability, so that it allows us to really, treat our patients with less frequency of treatment. And so there have been a tremendous number of agents that we use day to day in our practice that really didn't exist, 2 decades ago. And when I compare that again to geographic atrophy, if I gave this talk a few years ago, there wouldn't be much else to say because there wasn't really any other treatment that's available. But I hope to share with you some of the advances that are happening. The first is a very simple one, and it's something that we have access to already, which is those vitamins, the AREDS 2 vitamins that we discussed before. And this was a paper that came out just last year in 2025 that was basically one of the first main research studies to look at whether the vitamins at all make a difference in patients who have geographic atrophy. And I think you'll find that the findings are pretty interesting. So, this was based on the original trials which looked at patients with the earlier form of macular degeneration. Some of them, of course, developed geographic atrophy, and we wanted to now look back to see whether there was a difference in those who used the vitamins versus those who did not in terms of how much geographic atrophy actually developed. And so to study this question, they looked at 2 main outcomes. The first was, were the lesions growing in size? Just a general kind of area of the lesions to see whether they were growing. And the second looked at the location, because as we know, location is so important in this disease. If the disease starts to involve the fovea, that's really where a significant loss of visual function can happen. And so they looked at whether the lesions have a higher or lower tendency to grow towards the center of the retina with the use of these vitamins over time. And so these numbers basically showcase that while the actual size of the lesions did not change over time, the growth towards the center of the retina actually improved. So there was a slower growth towards the center of the retina in patients who used the vitamins. And that was really, the first time that we as retina specialists received this type of information to say that not only can we use these vitamins in patients who have, the earlier form of macular degeneration, but we also might be able to use it in a more advanced form, i.e. this geographic atrophy, to prevent the growth of the geographic atrophy atrophy from entering into the center part of the vision. So I think this really helped us, to rethink about how to use, these eye vitamins in our day-to-day practice. And so we know that the vitamins, they don't prevent the loss of existing geographic atrophy lesions, but they can help prevent progression of the new lesions over time. And so the next treatment I want to go into is another injection-based treatment, similar to how the current wet macular degeneration drugs are injected into the eye. These new treatments are also injected into the eye. They're based on this system, what's something called the complement inhibition. And so that's just a fancy way to say it's based on the body's immune cells. So we think that macular degeneration is in and of itself an immune-related condition. And so if we can somehow block the specific immune targets that are leading to the development of geographic atrophy, we may be able to halt or prevent the progression of this disease. And so that's really the rationale for why we would consider inhibiting these complement, these immune markers. And so this is a pathway of the normal kind of immune cells in the complement cascade. There are different markers that are involved, including C3 and C5, and different medications have been developed to actually target different parts along this pathway to prevent that immune response and to prevent the growth of the geographic atrophy lesions. Similar to what we talked about with the vitamins, these medications are not there to reverse the growth of atrophy lesions that have already occurred, but they're more there to prevent further vision loss. And so now good studies have been designed where they've compared patients who receive these eye injections that have inhibited the immune cascade versus those who did not, and actually found interesting results. And I hope to share two of these studies here. The first is for a medication called pegcetacoplan, which is one of the markers that is targeted by this medication. And so they, again, randomized patients. They randomly assigned patients to either receive the medication or to not receive the medication. Overall, they did 2 big studies, recruiting about 600 or so eyes into these studies. And so I just want to show you the graphs here. The numbers are less important, but if you see here on the left-hand side, the patients who received no treatment were the gray line, so you see the growth of their lesions over time. And then the patients who received the actual treatment, they received it either every month or every other month. That's the blue and the red line. You see a difference between the two sets of lines. This is an analysis that goes up to 24 months of treatment, so about 2 years of treatments. And you see, at the beginning, maybe month 6, there's not really a huge difference between the two groups. By month 12, there starts to be a little bit of a difference. By month 18, there's even more of a difference. And by month 24, there's quite a bit of difference, And so numerically, there's about anywhere from a 14 to 16% reduction in the growth of these lesions over time. Now, with these short-term studies, when we look at month 24, the visual acuity or the amount of vision that the patient had didn't really change because many of these lesions were outside of the visual center, and so even though the lesions were able to not grow as fast, they didn't necessarily improve the vision in this limited study. But now, as we get more and more data over time, now we look into month 36, there are new markers which are showing us that potentially there may actually be a visual benefit when you give these medications over a prolonged period of time. The analogy I like to think of is that if you take a boat and it's going from Europe or it's going from, the UK and it's sailing, towards North America, if you, at the beginning of that trip, if you change the degrees of that boat just a few degrees over, and then you see what the position of the boat in its original position versus where it was changed, there might not be too much of a difference by a few days or a week. But if you then start looking kind of many weeks down the road, and when it eventually reaches the other continent, one boat may be in North America and the other boat may be in South America, right? So that's just an analogy to showcase this principle that, at the beginning, if you do 1 injection, 2 injections, 3 injections, there may not be a huge difference that patient would report to you. But if you look over the long period of time, over many, many years, if you continue with the treatment and you're persistent with the treatment, there really is potentially a benefit in terms of maintaining good vision in these patients with geographic atrophy. In terms of different side effects, obviously there are the side effects that any injection-based treatment would have, so risk of infection, risk of bleeding. Those risks are all thankfully very, very rare. This is a treatment that I in the clinic do many, many times a day, and thankfully the amount of time that I've actually seen infection or bleeding is extremely, extremely rare. There are, of course, those risks with any treatment, whether it's the existing drugs we give or these new medications. But one of the side effects that has been noted is that potentially these drugs may make the wet form of the macular degeneration slightly worse. So there were a few more patients who received the geographic atrophy agents who had a worsening of their wet macular degeneration. And so that's just something very important for us as clinicians to be aware about, so that we're monitoring for not only the dry form of the macular degeneration, but also the wet form of the macular degeneration to make sure that that doesn't get worse over time. Right now, this medication, which is called pegcetacoplan, has already been approved in the United States. So this is a medication that is commonly now being used in the United States. When I was, during my fellowship, when I was in my last year of training, I trained at the UCLA Center in Los Angeles, and we gave this medication commonly to patients. So, we do use it there in the United States. Unfortunately, it has not received approval for use either in Canada, so by Health Canada, or in Europe. And so it continues to be used primarily in the United States. I want to showcase another medication. This is another complex name of acnicapnode pegol, which is, when I showed you that pathway of the immune pathway, this targets another part of that immune pathway. And so similar type of idea, they compared patients receiving the medication to not receiving the medication to see how they did over many months. And so, many hundreds of patients were enrolled in these studies. And so, again, looking at first at a short-term basis. So when we look till month 12, again, the two lines. The blue line is those who did not receive the medication, and the red line is those who received the medication over up till month 12. And there was about a 14% difference in the growth of these lesions over time. But I think what's really much more powerful is then, again, when you extend this data out. And I want to thank Astellas for providing some of this kind of very recent data that looked at these studies and how patients did over many months over time. This analysis looked at up till month 42. And so, when you look at the early data, there's, again, maybe about a 15 to 20% benefit, but then when you start looking out further, there may be a much higher benefit, up to 30% of the benefit. And then when you look at patients who were started, for example, those who originally did not receive the drug, and then they received the drug after the study concluded in the 24th month, and then you looked up to the month 42, there was actually anywhere from a 37% to a 40% benefit in those patients who did not even receive the drug at the very beginning, suggesting that it's really a dose-dependent relationship. The more of the drug you give over time and the longer you wait, the more of a benefit that you're likely to experience. Again, in the early studies, when they looked at month 12, there was not really a difference when it came to the visual acuity as a marker. And so this medication now, the trade name is Izervay. This has again been used in the United States, and we have experience in the United States using it. And they are now, submitting their application to Health Canada. And so we are hoping that in the near future we'll have a decision from Health Canada as to whether we are, as retina specialists in this country, allowed to use this medication. And so that's kind of where we stand right now. If Health Canada then says, yes, we are allowed to use the medication, this is something that is likely going to be rolling out in clinics across the country, and at that point, obviously, there are going to be other questions as to, which are the appropriate geographic atrophy patients to treat, which might not be the appropriate patients to treat, and this is something that we as retina specialists in the community are going to have to reconcile, and it's something that we are already thinking about as we learn about these drugs in their kind of real-world use based on our colleagues in the United States. The drug also has been approved in other jurisdictions like Japan and Australia, and so over time we're seeing more and more of an uptake of these medications. I want to just also highlight a few other areas of treatments that are being investigated. The first is well, we have all of these injectable treatments. There are now 2 that are being used in the United States. Could there be a medication that could be an oral pill so that you don't actually have to inject a medication in the eye? And one company called Belite Bio is actually looking at this concept to look at whether there could be a pill to treat patients with geographic atrophy. And this pill is based on regulating vitamin A. We know that vitamin A is very important. Its normal function is very important to have good vision, but vitamin A can cause some toxic byproducts and can sometimes be damaging to the retina if it's given in high amounts. And so this treatment by Belite Bio is actually looking at this question: could you actually change the vitamin A regulation to actually improve or reduce the progression of these geographic atrophy lesions? We don't right now have an answer to this question because this is right now the study is still being conducted, but it's something in the future hopefully we will have an answer to. It's interesting, they've also applied this treatment based on the vitamin A cycle to patients with Stargardt's disease, which is a condition which is an inherited retinal condition that previous to this didn't have any good treatments. And very recently, in December of last year, they provided good data showcasing that patients who had atrophy in the context of Stargardt's disease had a lower progression of their disease over time with this new oral pill. And so we're going to have to see whether the same conclusion applies to patients who have geographic atrophy. And so this then brings me to, okay, well, this is all good and great for patients who have these lesions outside of the center of their vision, but what do we do about the patients who have already lost their vision, patients who the geographic atrophy has already gone on to the fovea, and the patient, has poor visual function already? Astellas is developing a new stem cell-based treatment for this condition, where stem cells you could think of as kind of general purpose cells that can transform into different parts of cells from other different organs. Some can become skin, some can become heart tissue, some can become tissue in the retina. And so these specific stem cells that they're looking at, they're trying to program so that the stem cells try to develop more into normal retinal tissue. And actually, if you inject these stem cells into the eye, into the back of the eye, the goal is to see whether these stem cells can actually become viable retina tissue to help patients who have already lost their vision. Now, this is still in kind of early stages of experiments, and other teams have looked at this stem cell-based approach as well, but this is more just to let you know that there are groups out there that are working on different stem cell-based treatments that may one day, also impact the lives of patients who have already lost their vision from conditions like geographic atrophy. So overall, geographic atrophy is a sight-threatening condition, and it's insidious. It grows over time, and it eventually envelops the visual center, and it eventually impacts patients' functions. And right now, today, in Canada, we don't have any treatments, but I'm hopeful that we will, have treatments for this condition in the future, which can meaningfully, maintain good vision in patients over time. Different treatments that we discussed today are the 2 injection-based treatments that are already being used in the United States, one of which is potentially will be used in Canada if Health Canada grants that approval. But other treatments might include oral drugs, drugs by mouth, or these potential stem cell-based treatments, which is used in patients who have already lost their vision. And so I hope that these treatment options become a reality, but I think overall it's a very exciting time for us in the world of geographic atrophy. So thank you very much for your time and attention. And I'm happy to take any questions if anyone has.
I can just say there were a couple of questions that I received from people who were online, but their questions were completely answered in my mind by Dr. Popovic. They all dealt with emerging treatments. So thank you.
Any final questions? I think there may be a question there. Yes?
Patent just have thought the art altogether in the lines or results in the areas. I have a question about lots of AMD, but talking about the costs and injections and vitamins available out there here in Canada, are they covered by government?
Yes, so that's a very good question in terms of the cost of the various medications. So we're very lucky in Canada. So I'll just give you an anecdote from my time in the United States, where I treated patients in the United States who did not have good health insurance. And, you know, it was a very unfortunate situation sometimes because you knew what the condition was, even if it was conditions like macular degeneration. You knew what to do. You had the injections available to you. But unfortunately, sometimes I could not give the right patient the right treatments because of these issues exactly in terms of health insurance. So I really just want to contrast that to our state in Canada, where I feel, you know, the coverage that we have for some of these treatments is much more well developed. And so we as retina specialists, I think, are very lucky, and as Canadians are very lucky to have many of these treatments covered. Now, you know, it's not covered in absolutely every case. So these, for just talking now about wet macular degeneration, the therapies, if you're over 65, you have macular degeneration, you know, it'll be covered by the government. You know, patients, for example, who might be younger or might have diabetes in the eye or other situations, who may have, who you know, they might not have, you know, an automatic coverage by the government, but if they, you know, if they have other programs like Trillium and other things, they may be covered. So it's kind of more of a case-by-case basis. In terms of some of these new medications that are coming in for the treatment of geographic atrophy, the thought is that if they receive approval by Health Canada, then they will, you know, then there will be a discussion with the government as to what the price of the medications is going to be exactly. And our hope is that they will be covered as well for, you know, for patients in the demographic of macular degeneration, which, as we know, affects those over 65 typically. So we hope to have the treatment, you know, approved hopefully and hopefully covered as well. Yes, there was a question at the back.
Thanks very much for that nice talk. Milton Charlton, I'm wondering why hasn't Health Canada approved the C3 or C5 inhibitors? Have these other papers come out so recently that they have not considered the long-term studies, or what's the deal?
So that's the thing. I think as we gain more information over time, you know, it provides a stronger and more compelling argument to those in Health Canada to approve the treatments. The problem is, so here's the problem. So in the United States, the FDA, which is the regulator there, said that you can use those graphs that I showed you, the change in the geographic atrophy lesion over time, that was an acceptable kind of outcome to look at. So if you improve that outcome, that they would grant an approval. So they've already kind of been very clear with that. And so then when they showed that there was a difference, they were able to receive that approval in the United States. But because these are some of the first medications that were even approved in the United States, not all regulators like Health Canada or others in Europe or whatnot necessarily kind of prearranged that to be the outcome of choice. And so I think right now there are probably internal discussions with Health Canada as to, you know, whether the data that I've just shown you, whether it's sufficient enough to justify the approval or whether, you know, the companies need to provide further data. You know, my personal take on it is that, you know, I would prefer for the medications to be approved so that retina specialists actually had a chance to use it. And then I think that medications would be best suited in the retina specialist's hands, because then they would see which of their patients are appropriate candidates and which patients may not be appropriate candidates. And then, you know, you provide the onus of the treatment, of the burden of treatment on the retina specialist to decide, you know, which patient is an appropriate candidate. I feel like that's a much more kind of nuanced and a better approach than just to say, you know, it should not be approved, no one should receive it at all, you know. So, but this is an ongoing discussion. This is an ongoing discussion. I'm not, you know, 100% sure that they're going to approve it. We're going to have to see what happens. But you know, as time has gone on, as I said, more and more jurisdictions, more recently Japan and Australia, have approved one of the medications, and so we are kind of gathering more approvals over time. But we'll have to see whether that translates to Canada as well.
Thank you very much, Dr. Popovic.
Thank you.
We're very fortunate to have another patient in our audience who is experiencing some of the issues that Dr. Tao and Dr. Popovic have talked about, a patient with geographic atrophy. And we'd like to ask Gustavo Pérez Criollo to take a couple of minutes and tell us about his experience as a patient with geographic atrophy.
I am Gustavo Pérez. I am from Venezuela. I'm a Dr. Popovic's patient, and unfortunately, I have a macular degeneration. And because of my age and my English, I am 88 years old, and learning a new language is very difficult. I have to read something. I'm sorry. I had bleeding in my right eye. I have a scar right in the center of the macula. So I only have peripheral vision through my right eyes. In my left eye, I have a geographic atrophy. What are the symptoms? I need more light to see, for example, a restaurant menu. Another symptom is that more so before than now, I see things blurry in dimly light places. When I go to sleep and turn off the light, I see a shadow or dark spot on the white ceiling through my left eye, which fortunately is transparent. If not, I couldn't see at all. Otherwise, my vision would be only peripheral, so I wouldn't be able to drive. I also wouldn't be able to walk without help. I am hoping that Dr. Marko Popovic can slow the progression of the disease. I am very grateful to Dr. Marko Popovic because my macular degeneration is slow, is very slow. But I want to share with all of you a thought. There are unpleasant circumstances beyond our control that make us feel bad. But that circumstances give us the opportunity to develop a virtue, humility. This consists of accepting our reality, which brings us down to earth. So we realize that we are only fragile creatures. However, we have resources to manage this situation, and when they are beyond our control, we can seek help, as with my macular degeneration. Thank you so much.
So I'd like to ask Margaret and Gustavo, please, to come up here and sit on the panel, and we have questions for you. So if anybody in the audience would like to ask a question, if you're in this hall, put up your hand and we'll bring you a microphone. If you're online, you can click the Q&A icon at the bottom of your screen. And you can type in your question and click send. That's about it. So click the Q&A icon at the bottom of your screen, type in your question, and click send.
You know, Marilyn and Gustavo, thank you so much, first of all, for sharing some of your stories. I mean, I really appreciate you reaching out, because obviously this is a large audience. And I think, you know, in conferences like this, a lot of the time they hear from speakers like me who go over the medical side and go over the studies and, you know, go over the information, but really hearing it from your perspective to see kind of what you go through every day, I think is tremendously, tremendously valuable for this audience to hear, especially for those who may not have, you know, vision loss. And so from the bottom of my heart, thank you so much for sharing your experiences with this group. And it's been an honor to work with you so far. So maybe we could just give a quick round of applause first. So I know you've both described a little bit about some of the different forms of vision loss that you experience, but I wanted to go into a little bit about just general functioning. Either, how do you feel that the condition is affecting your functioning? How do you feel the condition might be affecting your functioning? Describe to us your just day-to-day, and what you think, are there things that you can do, things that you find difficulty doing? Give the audience a sense of that.
As far as my functioning, I'm still carrying on. There are things from time to time. My husband and I like to do jigsaw or crossword puzzles from time to time, and once in a while those lines sort of move, and I think, now, where was 5 down? And that sort of hinders a little bit in that way. But I can't say that it's holding me up in any way at this stage, and I hope that I will continue as well as I am. But I can't see really where that it's having an impact on me. I just have to get used to seeing these floaters. I was baking cookies yesterday and putting them onto the cookie sheet and thinking, oh, what's that on top of this one? And of course it wasn't anything, it was just a floater. But just have to get used to that type of thing. But I don't think it really has affected me in any other way. So.
I am a very healthy person, but my eyes. But fortunately, the macular degeneration is stable. I can still drive. Most of the time, my wife is beside me, and the only thing I ask is what that sign said, no? Because sometimes I don't see. Probably it's the adjustment of my glasses, no? But I am functioning well still, thanks God. Thanks, Dr. Popovic.
Thank you. And it's very fortunate in both of your cases that one eye for both of you is kind of the bad eye, where you have the geographic atrophy and you have the scarring. The other, for both of you, I do treat the wet form of the macular degeneration in the good eye, and so a lot of the time you're able to function and do your day-to-day tasks based on your good eye. And so, a lot of what we've been trying in clinic to do is to, maintain that functioning as much as possible, because both of you are very reliant on that one eye. But it's really good to hear your perspective that, despite the challenges of not having the good vision in the one eye, that you're still able, in general, from a functional sense, to do, hopefully, most of the things that you can do day to day. Do you find that you have any supports, or do you find that you need any supports in your day to day?
I can't think of any right now. I mean, my husband is a wonderful support to me around our home, and but I can't think of anything. Once in a while I have to ask him, what does this say, if I'm reading something, but apart from that, I'm happy the way I am, and I just hope it doesn't progress downhill.
Mm-hmm.
I think I don't need any support by your service. I'm feeling very well. I'm sorry, I want to be humble, but I think I have the virtue of adapting and accept everything, and I'm still functioning.
Thank you. Thank you so much. Tell me about the first time you realized that you had this vision loss and how that conversation went with the doctor and, I guess how you felt at that time when you realized that it was a vision loss, that it would affect one eye, when you realized that it might be permanent, that it might be very difficult to kind of treat that type of vision loss. What was going through your mind at that time?
The first time that I found out about this, I guess, was with another doctor, and it was looking at the grid and realizing that the lines weren't straight, and yet, when I looked with the other eye, they were straight. And that was the first time that I was aware that there was a problem, and nothing much was done at that point, and so then we switched over to you, and we're grateful for the help that you've given me, and long may it continue.
I think, I'm sorry, my English is not very, very good. My hearing, sometimes I don't get everything.
No, it's perfect. It's perfect.
You say. But as I said, I function very well. Even though I have that macular degeneration, I don't have a central vision through my right eye, but I am functioning. I'm functioning.
Good, perfect. I want to next go into, because I'm very curious, in a busy clinic day, we're talking about treatment and diagnosis and everything. I'm curious your impressions of our clinic visits in general, or, how it's been with other doctors and myself, like just being in a doctor's office, for someone who doesn't know what you do when you come to the clinic, walk us through from your perspective what it means to come to the clinic, what type of tests you might do, and how that day looks like. What might be some of the good things we do in clinic? What might be some things that we can improve on in the clinic? I'd be interested to hear your thoughts on that.
Being at the clinic, I see another doctor first, and they test the eyesight and do, check on things, and then eventually they go through all that, and then I see Dr. Popovic. And getting the injection in the eye is, I hope it's a blessing. I found it was more of a help, the first one I had. The second one, I didn't find it was as much of a help, but hopefully that may have just been a one-off. And but I feel you have time to talk to us, which is good, and answer our questions. And I feel very satisfied and very comfortable going and trying to get answers. So.
I have to say something respectfully. I am grateful of being Canadian right now, and I have a very good service in the health service. But I have an observation. Most of the doctors, respectfully, treat us patients like a thing. I see your eye, it's not you. Okay? I like you very much. You are very, very kind people and talk to me and everything. But I had another physician that treated me, almost say hello. Okay, you are stable, okay, take that pills, ciao. I think, because I'm dentist, retired, and I just treat my patient, not only the mouth, but I feel my patients how would I say, miedo, problems. They felt or feel scared, and we have to treat. I think it's my advice, my humble advice. Physicians have to treat not only the eye or the stomach, but we have to feel a patient's emotions. That's my advice. You are very good. Dr. Popovic is good with his patients.
Thank you. And feel free to be honest, by the way. But no, I think that's such a tremendously important lesson that we as physicians also need to carry in, because we go through our day-to-day as well, and we're seeing patients, we're reviewing the imaging, we're doing the eye treatments and everything. But I think it's just so important to remember that these are people at the end of the day, people with fears and anxieties and hopes and dreams and everything. And for us in this position of privilege, we need to make sure that we treat not only the eye, but also the patient. So thank you for that very, very important lesson. I'm sorry? Doctors are humans after all? Doctors are humans after all, absolutely. I think there was a question at the back. Yes?
Hi there, I'm Dr. Balafan, an optometrist in the area here, and I just want to hear a little bit more about resources in the area beyond just the healthcare and the injections. If there are other resources that you find particularly helpful, support groups or CNIB, VLRC, if there are other people or places and services that you go to that are particularly helpful for managing your symptoms.
So have you connected with CNIB or Vision Loss Rehab Canada, or have you felt the need to use any of those services so far, or not yet?
No, I have not used any other services. I'm hoping for solutions from you.
Okay.
And so far, we're working.
Okay. Thank you. Yeah. It's a great point, and both Marilyn and Gustavo, their vision in their one good eye is still quite good, and so I intend to keep it that way, and I hope we can keep it that way. And so I'm very glad that you haven't felt that you're without hope, but definitely for my patients, the patients who have bilateral GA, subfoveal GA, who have significant visual deterioration in both eyes. I think that they're tremendous services. Not to say, even in their case, services like the CNIB and Vision Loss Rehab Canada can be of use and can be of help. But I think it goes to show you just their level of retained visual function, how important that is in their own day-to-day. So thank you for the great question.
Can I ask a question? Yes, of course. I'd like to ask you a question. You saw the data that Dr. Popovic presented that showed that these new medications that are coming out are effective in the long term, but they're effective at controlling vision where it is currently. Could you comment as to whether medications like that don't improve your vision but enable you to maintain your vision for much longer, what that would mean to you personally?
Well, I think I would be happy to have that and not deteriorate anymore. If I can live with the way it is now, and if it's a matter of keeping it at that level, I would be quite satisfied with that.
Perfect. Well, thank you. No, and I think on our end too, all of the data, all of these medications that we talk about relevant to GA, I think it very much requires a shift in mentality, because I think, in clinic, patients with wet macular degeneration, we're very used to this kind of quick reward. We do a single injection sometimes, the patient can notice a significant benefit in their vision, and then the rest of it is really just maintenance over time. And so, you have the natural patient's buy-in because they see their vision improve, and they realize that this is not us just telling them, it really does work. Versus all these treatments that I'm showing you, it requires a high degree of treatment over time, and for a long period of time to actually see a maintenance in their vision. And so you don't get that kind of immediate benefit, I guess. And so I think, as these treatments become more mainstream, that's really going to require a shift in mentality, in both from the doctor's perspective as well as from the patient's perspective. I think there are a few questions here. One question at the front.
Thanks very much. It's Ian White from Vision Health Canada. I want to commend you both for coming forward and speaking about your experience. This is really, really, really valuable. I wanted to follow up on the point that Gustavo made about the fear that is inherent in a diagnosis of a degenerative eye disease. And I wanted to just reiterate this idea that what you carry away from the doctor's office is the anxiety of the unknown. It's not knowing what's going to happen in the future, what aspects of your life are going to be impacted, and how you might be able to cope with those things. And that's why the question of resources is really important. Getting connected with Vision Loss Rehab Canada, getting connected with CNIB or Balance for Blind Adults, or the Canadian Council of the Blind, which has active chapters all across the GTA and all across Canada, actually. These are invaluable resources that can point you towards a lot of the community-based resources that are available for people coping with vision loss or even anticipating future vision loss. So I want to reiterate that reaching out even before you think you might need access to these resources, or for the medical professionals who are dealing with patients, being knowledgeable about the resources in your area and how to get connected with them is absolutely vital to allaying many of those fears and anxieties that are inherent in a diagnosis. So that's more of a statement than a question, but if you want to comment on that, I'd appreciate hearing your side of it. Thank you.
Thank you for the excellent comment. I think it's really, really important to put that into context. And seeing it from the doctor's side, I think there's very, very much, both the first time you make the diagnosis and telling patients, how are things going to look like moving forward, and then especially with respect to treatments, if treatments need to be given, especially when there are injections in the eye, there's a tremendous amount of fear and tremendous amount of anxiety that exists in that. And I really, as much as I can, to try to take as much time as I can, especially in those initial encounters, to answer as many questions as I can to reduce the fear as much as I can. But I realize that it's something that's with them is going to stay with them for a very long time. And so I think knowing which support networks exist is an incredible point. So thank you for bringing that up. I thought I saw another question or comment. Yes.
As Marilyn's husband, I just wanted to add one little comment. You asked how it affects daily life.
Yes.
One thing I notice about that Marilyn has difficulty with is anything that requires very close attention, like getting the key in the lock, trying to see where the lock is, and also doing up a zipper.
We'll just ask you to, just so that the other audience members can hear you at the back.
Okay, just a couple of comments about daily living that I see my wife Marilyn coping with or trying to cope with is close things like getting the key in the lock and doing up a zipper. These are things I find that she has often difficulty with. Thank you.
Thank you so much, Mr. Broughton. We really appreciate your perspective as well. That's very helpful for us to know. I wanted to open it up to ask if there are any other questions that we may have not. Yes, I think there's a question here at the front as well.
Thanks so much. I want to raise sorry, my name is Ashley Shaw. I work at Vision Loss Rehabilitation Canada. I don't have macular degeneration, but I've been blind since birth myself. So I just wanted to ask a question, and I don't know which of you, doctor or patients, if you want to address it in your own way. I want to raise something a little bit difficult to talk about, which is just when an experience that it doesn't sound like either of you have come to quite yet, where maybe someone is starting to realize that the daily activities that they want to do or have to do are being affected by their vision loss, and maybe the treatments aren't quite at that stage where they're halting, or where the vision loss has progressed beyond a point where just having a drug therapy or a type of treatment is helping. I know it's so difficult to think about that concept, but I'm really curious about where that space is of supporting someone. So maybe for our doctor, what's your kind of thought process watching someone go through that experience of realizing that maybe some non-visual skills or strategies might be helpful, or some vision maximization strategies, or some of those pieces that we would more think of as rehabilitation might be helpful, in concert with or separate from kind of drug therapies. And for the two of you who are patients, and thank you for sharing your stories with us, what would you find to be helpful, if you can? I know it's an uncomfortable thought, and I'm sorry for raising it in this way, but what would help you to know when you might need access to some additional resources, or to sort of cooperate with or go alongside your treatment?
Well, thank you so much for the great question. I'll answer it from my vantage point. When it comes to this, I think of kind of multiple different domains of support that could exist, or, in some cases are there, in some cases are not. I mean, the first is when a patient, when we make a diagnosis like this, and when we kind of clearly tell the patient about, their long-term visual potential, the fact that there may not be treatments available, I think one of the first emotions that happens is the patient might feel very alone, that they're approaching this, by themselves, that they don't have anyone else to reach out to. And I think, having a good patient-physician relationship, I think, is the first fundamental thing, to at least give the patient a sense that they're not fully alone, that they have someone that understands their condition, that someone that's going to follow them. For many conditions which have been incurable for a very long period of time, we're at the time now where even for inherited retinal conditions, we're able to, there are different treatments that are being investigated, and so I share that knowledge with patients as well. Not to give them a false sense of hope, but just to let them know what may be coming in the future. So I think establishing a good patient-physician relationship is incredibly important. I think for that person then, of course, in terms of other supports, their own direct family, friend, their own direct social network is an important source of support. Unfortunately, many of those people, in many cases, don't have similar challenges, and while they're able to support the patient, they don't really understand how they truly feel. But I think that's still valuable as another kind of domain. The third is obviously their community, and that's why we have here, representatives from the CNIB, from Balance, from VLRC, from all of the different stakeholder groups, where patients can get connected to these organizations, which have a wealth of information, supports, resources to help patients navigate, their world in the most optimal way, despite their visual challenges. those are some of the other doctors that I closely collaborate with are low vision rehabilitation specialists as well. And, they approach the problem from a very practical lens in terms of what are specific vision strategies or instruments that can be used depending on the exact nature of the vision loss in order to kind of maximize that patient's existing vision depending on what condition that they have. And so, I regularly refer my patients to low vision rehabilitation specialists as well, from that side of things. So I think, approaching it from this framework of having kind of multiple domains or multiple spheres that you might think of as possible supports, I think is helpful. Obviously, it's impossible to regain the vision that patient has, and that patient will always have, a sense of fear and anxiety and everything, but I hope through these various pathways, it makes it at least a little bit more palatable.
Thanks very much, Marko. Thank you very much to our patient panel. Let's have a round of applause for them. Thank you so much. And thank you, Dr. Popovic. While the panel is leaving the stage, I wanted to move on. During the presentations of the two doctors this morning, we heard a lot about new medications being approved or potentially being approved by Health Canada. We thought it was important to give you an understanding as to how the approval process works at Health Canada. And to do that, I'd like to introduce Dr. Norman Chan of Astellas Pharmaceuticals, and Dr. Chan will tell you all about it. Thank you.
Thank you, Keith. Thank you, Keith. And congratulations to Vision Health Canada, and to Michael and Ian and everyone who organized this event. It's incredible what you've been able to accomplish in such a short period of time. So good morning, everyone. My name is Norm Chan. I'm the Global Medical Affairs Lead at Astellas. Astellas is a Japanese pharmaceutical company, and we've been operating here in Canada for over 30 years. It's my job at Astellas to oversee our ophthalmology portfolio of medications. So just full disclosure, Astellas is working on several treatments for geographic atrophy. Currently, those treatments are not yet approved here in Canada, but we're hoping to bring them to you very, very soon. It's both a privilege and a pleasure to be invited to speak with you today about what it takes to bring new medications to Canadians and what it takes to navigate the regulatory and reimbursement pathways here in Canada so that patients can ultimately benefit. So the drug discovery process starts by asking a relatively simple question. Where can we make the biggest difference for patients? So we look for diseases where there are either no treatments or very few treatments, and there's a clear need for something better. So geographic atrophy, which we've been talking about this morning, is a clear example of this. So we will screen hundreds, if not thousands, of potential drug candidates to identify a few promising candidates. And we'll take maybe a couple dozen into preclinical testing for further workup. So preclinical testing will involve experiments in the laboratory where we're further characterizing how the drug works, what its toxicity is, and identifying those that are promising enough to take into human trials. So human testing is split into 3 different phases, so phase 1, 2, and phase 3 clinical studies. And only after passing through all 3 of these phases successfully will a drug be taken to a regulator like Health Canada for their review and hopefully their approval. So this entire drug development process is a long and uncertain journey. There's a high rate of failure along the way. We have to start with thousands of initial candidates before we can end up with just one approved successful therapy. And most of them do fail along the way and are discarded, unfortunately. This journey can take anywhere from 10 to 15 years on average, and sometimes even longer. So it requires a lot of planning and incredible investment in time, energy, and resources. So So as we move through the drug discovery and development process through clinical research and human trials, we're involving more and more patients and physicians and research centers to participate in our trials. In the earliest phases in phase 1 trials, we're probably involving a few dozen patients. By the time we get into phase 2 and phase research, we're involving thousands of patients across hundreds of centers all over the world. And none of this would be possible without the patients that volunteer to participate in our trials, the academics, the physicians like Dr. Popovic, Dr. Tao, who lead our studies and make sure that they're conducted in the highest possible rigor. Now, one of the unique aspects of phase 1 research, this is the first time a new drug would be used in humans, is that these trials are typically done in healthy volunteers, so patients that don't even have the disease. And the reason we're doing this is because in this earliest stage, we're not looking to treat the disease. We're looking to understand the safety profile, to better understand how it affects the body, and to make sure that it's appropriate and safe enough to move forward with larger and larger studies. As we get into phase 2 and phase 3 research, it's at this point that we're looking to establish the efficacy profile of the drugs, how well they work, how they should be used, what is the right dosage, how often should they be administered, as well as further establishing the safety profile of these products. Only after they've gone through this rigorous testing across thousands of patients and hundreds of research centers will a drug be ready to take to regulators like Health Canada here for approval. So Health Canada is our federal department. They are charged with protecting the health and safety of Canadians. They ensure that all medications are safe, they're effective, and they're made to the highest possible quality standards. When Health Canada looks at a new drug for approval and review, they're looking at the efficacy. They're looking, does this drug really provide a meaningful clinical benefit? They're looking at the safety. Are the risks acceptable and manageable? But also looking at what's the balance between those two? Do the benefits and the efficacy of the drugs, does it outweigh the potential risks and side effects? They're also looking at the chemistry, the manufacturing of the product. Is it consistently produced at the highest quality standards? And they're also looking at all the accompanying information, the labeling, to make sure that it's clear, concise, and provides all the information that physicians and patients need to take the drug safely and properly. So when we prepare to submit a new drug to Health Canada for their review, we're providing them with all of our clinical results, our manufacturing, chemistry, and all the product labeling. And this package will be thousands of pages long. In some cases, it'll be over 100,000 pages long. So that just gives you a sense of just how much evidence and research goes into developing these new medications. It's a monumental task. So when Health Canada receives this massive document, it goes through a screening process. They're looking to see, are all the modules that they need, all the information that they need to complete the review, is it correct and in place? And this review typically takes about 45 days. After it passes screening, then the actual review of the actual information takes place. This typically takes about 300 days on average. So you're looking at about a year from start to finish for the review, pending any delays or other unforeseen events. Now, once Health Canada says, yes, this is approved, it's a safe and effective product, it does not automatically mean that the drug is covered and paid for by public drug plans. In Canada, we have a separate public reimbursement review process. And a key step along the way is the health technology assessment, the HTA review. And it's their job to determine whether the medicine provides a meaningful benefit, a meaningful value for both patients, but also for the broader healthcare system. So in Canada, there are two bodies that take care of this review. There is the CDA, the Canada's Drug Agency, but also INS for Quebec. After the HT review, it goes for price negotiation with the Pan-Canadian Pharmaceutical Alliance, or the PCPA. And it's their job to make sure that the drugs are affordable. And once that's done, it's up to each individual province and territory to determine whether or not they're going to pay for a new medication. So you could have certain situations where, for example, Ontario will decide to pay for a new medication, but another province may not, or vice versa. So this entire process can be quite lengthy, on average maybe about a year and a half. However, that's far from a guarantee. And there's certain situations where Health Canada will say, yes, we're going to approve this medication, but ultimately it does not get covered by a public drug plan. Now, in parallel to this, there's also a private review pathway where private insurance companies and drug companies or private insurance plans will review medication for coverage. Oftentimes, you can get faster approval through through these private plans than you would through the public system. But there could be some great variability between different insurance plans in terms of what is covered at what level and at what time. So that was a very high-level whirlwind tour of what it takes to develop new medications and navigate the regulatory and access pathway. I hope I've given you a sense of just how much time, effort, and collaboration is required to bring these new medications to market. And I do want to make a special thank you to all the academic researchers that dedicate their lives to understanding these diseases better, to allow us to develop new medications. I want to thank the physicians, the researchers that help run our clinical trials and generate the evidence that we need. And most of all, thank the patients that volunteer and allow us to do these clinical trials and generate the evidence that's needed. None of these innovations and advancements in the field of medicine would be possible without everyone's collaboration and dedication to advancing the field. So thank you.
Want to take a question or two?
Yeah, I'd love to take any questions if there are any. I'm also around the rest of the day, so continue the conversation over lunch as well.
I'm wondering about the advocacy side of encouraging drug approvals in Canada. Keith Gordon will remember a number of years ago that that CNIB, I should say, did have a national advocacy program in the area of AMD treatment. But when you hear about drugs that are been used for 10 years and 5 years in the US successfully, and they're not available in Canada, I've always wondered why, and is there anything that we as citizens can do, or is there a real issue with bureaucracy, or does the drugs in the US not working and we know it and they don't?
Yeah, so you made some great points there. In terms of the importance of advocacy, it's paramount to the Canadian review process, and it's actually built into the review process. So the CDA and INS, so these are the agencies that are charged with determining, making the recommendation for which drugs should be covered and approved here in Canada. And they have a formal process to allow for physicians and patients and advocacy groups like Vision Health Canada, like Fighting Blindness Canada, to provide their input and weigh in on the importance of new medications and which should be approved here in Canada. In terms of disparity about what's approved in different countries, so every country has their own regulator, their own pathway for approvals and coverage. Sometimes they're looking at recognizing different endpoints and are taking different things into account. Sometimes advocacy may not be as strong in certain countries, but I think Canada is uniquely positioned, especially in the ophthalmology field. There's such strong patient advocacy groups that have been working in the space for decades, have done such great work. So I'm very confident in what we can do here in Canada.
Good morning. Just a very quick question. You mentioned about that Health Canada has its process that takes about a year, and then there's the HTA process, and then the provinces get involved in what they will fund and what they won't. If you are able to comment on that process, is there a way to streamline it or compress it or rearrange it in some way to speed the process? Like if we know a drug is effective and the likelihood of a positive from Health Canada is high, is there a way to shorten the timeline to get that product into the hands of physicians so that it can be made useful in the general public?
Yeah, thanks, Ethan. Thanks, Ian. Absolutely. So there are mechanisms in place to allow for speedier approvals in certain situations. So Health Canada does have an expedited review process. It basically cuts down the review time in half, but it's only granted in certain situations where there's high unmet need or it's a life-saving medication. It's granted very sparingly. In terms of speeding up the reimbursement process, there are certain pathways where you could file for into the HTA review before you've even received Health Canada approval within 6 months before approval. So that does also speed up the time frame as well.
Hello. My question might be similar to the two that were just asked, but in context of us as a consumer looking for drugs that may be useful to be approved sooner, you went through the process. Where does Health Canada become involved? Do they get involved as you're researching and developing the drug so you know you're going down the right path? Or do they only show up when you're presenting them with a finished product?
Yeah, so it's important to involve the regulators as early as possible to make sure that your study designs are appropriate and will generate the evidence that regulators are working for. Typically, large pharmaceutical companies they'll definitely consult and have meetings with the FDA in the United States, usually with EMA in Europe. To be perfectly honest, Canada isn't always at the top of the list, and they may not be consulting with Health Canada at those early development stages. We would have meetings with Health Canada before filing the medication to ensure that we're putting together the right package with the evidence they're looking for. But that's the sort of the stage. Once we have the data in hand is typically when you would go to Health Canada. Other regulators, we might go sooner.
Thanks. There's one more, sorry.
Thank you. Just quickly and kind of clarifying from following the line of conversation so far, can you give us an example or talk a little bit about the difference in, I don't know if you would call it kind of effectiveness profile or effectiveness outcomes that maybe something like Health Canada would be looking for versus the FDA or something like that in the States or any approvers in the States, just to help us understand maybe, if something's been approved in the US and it was maybe developed in the US and has been going on for a little while, what some of those differences might be in terms of how the different agencies define effectiveness. Does that question make sense?
Yeah, so just speaking very broadly, generally speaking, most regulators are looking for a clearly defined functional benefit, whether that is an improvement in vision or whatnot. Not all study endpoints are functional endpoints. Sometimes they're anatomical endpoints. Like there's reduction in the thickness of the retina, for example, in wet AMD. So that is sort of a clear clinical benefit, but it is a functional benefit, and I think that's sort of up for sort of debate with different regulators.
Thank you very much, Dr. Chan. Give you a round of applause. I think this afternoon we will have a little session on this whole issue of a national eye care strategy for Canada as outlined in Bill C-284. And maybe there you will understand that there's been some advocacy to try and speed up the process of approval of new drugs. So maybe Ian White or Jennifer Urosevic could talk about that this afternoon. Thanks. I would like to have Dr. Marko Popovic come back. Dr. Popovic is not only a retina surgeon. Dr. Popovic conducts research at all levels. He has epidemiological background, and he's the head of a study that he's going to tell us about called the Ontario Eye Disease Prevalence Study. Did I get it right?
All right, excellent. Well, thank you, Keith, for the introduction. I'm really interested in sharing some of this information that we have with you. This all relates to the concept of the prevalence of different conditions. So we've talked very specifically about macular degeneration, conditions like geographic atrophy, but the whole reason why we do these types of projects is to learn how many Canadians out there have different forms of eye disease. Some of these eye diseases are glaucoma, some of these eye diseases are cataract, some of these eye diseases are the ones we've talked about already. And so I hope to share with you one of the studies that we've already completed looking at this question of prevalence, or how many people have different eye conditions, and one that we are in the process of working on. And I hope you'll find them interesting. This is a slide deck from the Canadian Ophthalmological Society where we presented this work as well. And so the basic rationale here is when, every research paper starts out and says there are X amount of people who have macular degeneration, or Y number who have glaucoma, or Z number who have this cornea condition. And a lot of those numbers that are generated in terms of our understanding of how many people have a certain condition are from large studies that were done in the United States. Many of them were done in the 1980s, when the demographic mix is much different than our contemporary population, and in the United States context, which may or may not apply to our kind of modern day Canadian population. And another thing to remember is that back in 2004, there was what's called a delisting for OHIP coverage of routine eye exams. So these were people who were aged anywhere from 20 to 64, who didn't have any eye condition otherwise. Prior to 2004, they could go to their optometrist or eye care provider, and they can have an OHIP-covered eye exam. After 2004, that was delisted, meaning that if you were healthy, if you didn't have any other eye condition, you weren't allowed to have OHIP coverage for your eye exam. You had to pay for it via private insurance or out of pocket or other mechanisms. And so that was a major kind of policy change that I hope to show you the effects of what happened after that policy change was made. And so luckily for the group of people who are 65 and older, they're still eligible for an eye screening exam. And so that's why we really wanted to compare these two populations, one age 40 to 64, and then the other age 65 and older, over a long period of time, anywhere from 1997 to 2021, and see whether this policy that was done in 2004 made any effect in terms of the number of people that were recorded to have various eye conditions. And so we used this large database, which basically records all OHIP procedures and diagnosis. So anyone that has any contact with any physician in the province goes under this database. And so we're able to use the database to basically see how many patients have different eye conditions over time. And so we used both the physician would tell us what the diagnosis is, but they would also use certain treatments that are given for certain conditions, and together this information gives us a good sense of which conditions were out there in the population. And so this was kind of an Ontario-wide analysis. And so just in terms of terminology, prevalence, when we talk about prevalence, that means that within a given year, at one point, how many people have this eye condition? That's in contrast to the concept of incidence, where we're looking for within a given year, how many new people develop the eye condition. And so I'll go over both prevalence information as well as incidence information in these slides. And so this is our first kind of overall look at the general prevalence. So looking at how many people had it in 97, 98, 99, et cetera, et cetera, et cetera. And so if you look, the blue line here represents any eye condition, and you see over time, obviously it's going up as more and more people are being diagnosed with various eye conditions in the population. And then when you break it down into specific conditions like glaucoma, cornea disease, retinal conditions in patients with diabetes or other retinal conditions, all of these do tend to go up over time. So more and more people are being caught with these conditions in terms of prevalence. Then when you break it down by age groups, so 65 and over, we see that over time, again, you have an increasing prevalence of these conditions being logged in the system in those 65 and older from 97 to 2021. And then when we look at incidence, the picture is a little bit different. So again, prevalence is at any year how many people have the condition. Incidence is how many new people are developing a condition in that given year. And so you see here, in the 40 to 64 group, when you look at before 2004 and after 2004, for most of the conditions that we were looked at, there was actually a sharp decrease in the incidence of these conditions in that time when that policy happened. So all of a sudden, we're not catching as many new people with the condition over time because of this policy change, because it's a financial barrier now to receive a regular screening eye exam. And so you see here that those patients who have glaucoma, for example, there were many fewer individuals with glaucoma after the policy change than beforehand. Same thing with the corneal diseases. Now, when we look at patients, as part of this policy change, they gave patients who have diabetes the ability to have an annual covered eye exam, a screening eye exam. And so when we look at those who have diabetes and have retinal conditions as a result of that, that thankfully did not go down as a result of the policy change, but the other conditions did, suggesting that the policy change really had us catch fewer of these patients since it happened. Luckily, because the policy change really affected those in the 40 to 64 demographic and not those 65 and older, you see really no effect. In the bottom graph, before and after the policy change, there wasn't really much of a change in terms of how many people we were catching with these various conditions. And the goal of all of this, in terms of screening eye exams and why we think that they should be important, is to catch diseases early, because we know that whatever the condition might be, early glaucoma or early macular degeneration or others, effective early treatment is much better, much more cost-effective, much safer, et cetera, et cetera. It has much more benefit than catching a disease later in its course. So if we're able to catch some of these diseases earlier on in their trajectory, before someone has turned 65 and older, that should be a benefit. And so that's kind of, in a real-world setting, what happened as a result of this policy change. So we did find overall that there was an increased prevalence of these conditions over time. However, when we looked at incidence, the number of new people developing each of these conditions, there was reductions in those aged 40 to 64 in terms of any common ocular eye condition and in terms of other conditions like glaucoma and retinal disease. And then we basically looked at what was the incidence before the policy change happened and what was the incidence afterwards, and we were able to compute this number of about what we think about 1.1 million people that were in the province, aged 40 to 64 years old, that are likely not being detected with one of these eye conditions because of the policy change. And so had the policy change not occurred, we anticipate that there would be approximately 1.1 million people who would be caught in the OHIP database with one of these various conditions. And so that was an important finding of our analysis. So again, there was less, adults who were 40 to 64 were less likely to use eye care services after the policy change, specifically for conditions like glaucoma and retinal disease, and that's likely as a result of an additional financial burden for those who may be low income, unemployed, or other scenarios. I want to thank ICS, who allowed us to conduct this analysis and to present this work to you all today. And I want to also thank my team, who was instrumental in developing the initiative. And so that is kind of the phase 1 of our prevalence study, which found all of this interesting information. Unfortunately, just mining through the OHIP database doesn't give us the full picture, because the OHIP database only tells us who is caught in terms of who is identified to the healthcare system, presents to their physician with one of these conditions. And ideally, we'd like to know what is the prevalence of any of these conditions in the general population. There are many people, as I just showed you, who are probably not being caught with some of these eye conditions. And so that's really the rationale for this second phase of the study, the Ontario Population Eye Disease Prevalence Study, which I hope to share with you today in terms of generally what we're planning to do. I won't go into this whole background, as I think we've covered most of this, but I'll go into the rationale of the study. Again, we're going to be comparing this time those aged 50 to 64 to those 65 and older to see what is the prevalence of sight-threatening conditions kind of at random in the population, and then extrapolate those numbers to give us a good sense of what is the population level for different common eye conditions. So this is going to be basically an ocular screening program that we're going to be starting. We're hoping to enroll a total of 3,000 individuals. We have no idea whether they have any eye condition or don't have any eye condition, and we're going to be randomly sampling them from different parts in the province to get a representative amount of individuals to look at these different eye conditions. So how are we going to do this? We're first going to do what's called random digit dialing. So we're going to identify, of the 3,000, how many individuals do we need to collect in each district or area of the province, and then randomly call individuals in that area to be screened in our program, and we'll provide various supports for those who have, disabilities, require wheelchair support, and other forms of transportation. So we're going to use this random digit dialing to actually identify the individuals at random in each part of the province. Then we are going to be collaborating with a group of optometrists who are working in close by to one of these areas scattered across the province. And then once we've identified a participant and we have an optometrist, we're going to connect the two and allow the person to have a fully funded eye exam at their optometrist office. And then we're going to, when the participant comes in, we'll collect various information about them, their age, their sex, race, income, et cetera, and we're also going to do many of these pictures that you've seen, looking at the retina as well as the OCT images that you've seen. We're going to be taking all of that ocular imaging information when participants are screened to see whether there are any abnormalities that we're able to identify. We're also going to be asking all of these participants about their barriers to accessing eye care. So do they normally access an eye care provider? Do they routinely do that? If they haven't been doing that, what might be the reasons they haven't been doing that, and what their level of insurance coverage is? That's going to give us much more of a better sense to see how many people may not be caught by our current systems and our current policies. We know that obviously many of these eye conditions don't exist in isolation, and so a lot of individuals who have eye conditions also have many other systemic conditions, and so we're going to take a significant history with respect to the rest of their body, whether there's any conditions or ailments with the rest of their body, and also be measuring heart rate, blood pressure, and glucose measurements in our participants to see if there's any relationships to some of the eye conditions. So then, once the patients have been examined, they've had the ocular imaging, they've seen their optometrist, the optometrist has made a diagnosis, or they might say it's all normal, then we're going to use what's called telemedicine. So we're going to securely relay all of those images that are collected to an outside ophthalmologist, who's an eye surgeon like myself, who is going to independently, they won't see what the optometrist has said, but they will independently basically verify that the patient either doesn't have any condition, or they will identify whether the individual has an eye condition. And so we're doing this kind of as, we're going to integrate redundancy within the system so that both the optometrist and the outside reviewing ophthalmologist have a chance to review the individual's story to see whether they have an eye condition, and that will give us the best reliability and validity to make sure that what we're capturing is accurate. So in terms of our outcomes, obviously we're going to be looking at prevalence data of all of these major eye conditions: macular degeneration, cataracts, glaucoma, and diabetic retinopathy. But I think the study will be very nice as it's designed to look at all of these other endpoints in terms of, one's systemic health and whether there's any relationship to eye health, their general follow-up, prior to entering into the study. And all of this information ultimately will allow us to provide an argument to go back to the government and to say, had there been a, ocular screening for all individuals, an annual screening eye exam that is OHIP covered, how cost effective that might be, because how many more eye conditions that we can catch that are earlier in the disease course and that we can intervene on earlier, as opposed to, individuals catching our clinics late and then not being able to intervene as good as we can. These are all just numbers to showcase that for the various conditions we're looking at, we think that the degree of precision that we need to collect about 3,000 individual participants in order to have a high degree of confidence as to what the prevalence of all of these major eye conditions are. So thank you very much for your time and attention. I hope that was interesting and of value, and I'm happy to take any questions.
I have the same type question as with the other speaker in relation to me, myself as a consumer, and this academic study. Where ultimately for any new programs to be approved by the Ontario Health, where do they get involved in this? Because to just go through this whole study, then present it to them, and they say, well, we'll get our experts and study it. Well, you are the experts and you've studied it. So when do they get involved so they know what you're doing? So when you finish, something can ultimately be created to benefit the public.
Yep. No, it's a great point, and we've already engaged the government with respect to this, and so they are already aware that this is something that we're going to be going ahead with. So the answer to your question is as early as possible, and we've already had those levels of communication. I mean, they really want to see this type of data, because they have continued things as is, and so the policy hasn't changed for many years. But this data, we believe, is going to be very compelling when it comes out to guide a change of policy, and we'll continue engaging the government as the study continues to evolve. Yes.
Thank you very much. I'm kind of ashamed to say that I don't know in Ontario policy whether people between the ages of 20 and 64 are entitled to an annual medical exam with their GP. If they are, would not a basic vision test be part of that annual checkup? And if the GP discovers there's something not good, that he would refer the person to a specialist?
It's a great point. Yeah, so to answer your question, we do still think that there is value in having an optometrist evaluate people, even in the ages of 20 to 64, just on a kind of annual screening basis. If let alone, I mean, they might be very healthy and it might just be kind of a quick glasses check. But the reason why is because, with the GP, first of all, they don't have a lot of dedicated tools to actually look into the eye and to make these diagnoses. They can tell, the patient can come to them and say, I have vision loss. At that point, sometimes it might be too late. It depends on what the condition is, of course, and then they would refer, which is what happens today. but they unfortunately don't have a lot of good screening tools to actually make a diagnosis, especially when it's in its early stage. Many of these conditions, glaucoma is the perfect example. We might follow people for a very long period of time to make sure that their optic nerve stays stable, that their vision stays stable, that they don't have any visual changes. And we might only intervene at the slightest start of any visual change. And so by the time that someone has lost a dramatic amount of vision, then they come to our office, sometimes there's not much we can do for many of these chronic conditions. So the bottom line is that screening is still important. Yes, a few questions at the back. Oh, yes.
My mother had, not sure if it was macular degeneration, but she, at the age of 75, she started losing her sight, and by the age of 92, she went completely blind. Now, question is, if your parents have macular degeneration, is it likely that your children will? And the point is that my macular degeneration was caught about 14 years ago. So I have macular degeneration, and my younger brother, who is 11 years younger than me, has macular degeneration, which was caught just a year ago. So the question is this given from parents to children?
Yes, and the answer is definitely yes. So there's a strong family history. If someone has a family history or a close family member that has macular degeneration, the chance that they develop the condition is much stronger. And we've actually, there have been large genetic analyses that have actually mapped certain genes that we know can travel within a family and that can be responsible for macular degeneration. So that's one of the common questions that we ask in clinic, whether someone has a family history of macular degeneration, because that very much influences their risk of developing the condition in the future. Yes, there was a question in the back.
Oh, should I stand up? No, it's okay. Oh, I'm assuming my mother had it, but we never knew when she died in her late 90s whether she had it or not. But I developed it in my early 80s, and much to my shock, my youngest son, who's 67, has just come down with macular. In one eye, I think it's dry, but is that not very young for him to come down with it? I'm kind of in shock over it.
Yeah, it's a good question. I mean, there's variability in the presentation. I wouldn't say it's very young. I mean, it depends on how significant it is. Right now, it might be on a kind of mild stage. But one thing that I'll say, which relates to this study as well, there's a difference between the time at which the diagnosis is made, like where a healthcare provider actually makes the diagnosis, and the time that it actually starts. So even though someone may be caught later on, they may have had the condition, but at a more mild stage where it wasn't as visually significant, perhaps even years before that, So I think it's important to keep those two things in mind. And that's really, again, goes back to this question of, prevalence and trying to catch conditions early, because we know for something like macular degeneration is the perfect example where, if someone's known to have macular degeneration, we need to follow them much more closely. And then if there's any onset of wet macular degeneration, we can intervene almost immediately. Some of the most tragic cases that I see in my clinic are those patients who have macular degeneration who are just discovered too late, and they have irreversible scarring, and I tell them I can, do 1,000 injections and it really won't help, and it's unfortunate because there had been a point at which there was a room to intervene, and unfortunately they're past that point, and so we want to try to have as few people as possible, entering into that stage.
Sorry, I just have one quick question. Yes. It's probably strange. I have trouble reading. And is it the macular or the glaucoma that would be causing that problem? Thank God for audiobooks. But I just have trouble reading. It doesn't even matter. I use magnifying glasses all the time, but it still just gets so difficult to read an article or something. Is that common?
That is very common, and it's probably, I would imagine, I haven't examined your eyes, but I would imagine it's more related to the macular degeneration than the glaucoma. The glaucoma normally, in its early stages, starts out in the far periphery of, of the visual field. So the far periphery is affected first, and then only when it's really, really severe does the center part of the vision become affected. That's completely opposite in macular degeneration, where it starts where the central vision is affected kind of right away. And so I would imagine that's probably more related to the macular degeneration.
Thank you.
Can we make this the last question, because the
I
lunch
love
is
this
getting
big,
cold.
big population data analysis. That's great. I was told recently that there's a huge increase in myopia. The word epidemic was used. I don't know that's appropriate. But as we heard from this patient, myopia in lots of people can lead to very severe retinal degeneration, quite a bit like AMD. Now, there's an idea that there's a critical stage when the eyeball gets the right shape, and it's fairly early in life, but in that time, you're supposed to be outside running around in the woods and not looking at screens. Now, the reason I'm bringing this up right now is in relation to your screening. It doesn't seem that children are being evaluated in school anymore, even with the Snellen chart. And I don't know if that's actually true, but I never heard of my grandchildren being evaluated for vision at all in school. It seems that part of your effort could go into persuading the authorities to reinstitute eye chart scanning by a nurse in public school at a very early age and see whether they can head off myopia developing in children.
Yeah, no, I think it's a phenomenal point. I mean, it's not the focus of this specific study, but in the future, it's something that definitely we would like to study and present good data on. I mean, there have been over time more and more of these programs that actually are screening children within the school, but unfortunately, there's not like universal coverage for that right now. And so, as part of the the bill that got recently approved to create a vision health strategy in the country, that'll be one thing that'll be very important, I think, in terms of screening of children when they're young, in terms of exactly as you're saying, myopia prevention, because we do know that that if myopia is not treated, early in life, it can lead to a condition called amblyopia, where there can be irreversible vision loss because the brain just tunes out that eye, basically. And once amblyopia is hit, there's really not much that we can do. So if children are very young, that's really the time to intervene about things like myopia. And so I think I agree with you that screening is tremendously valuable, and I'm hoping that there will be a more unified approach to that in the future.
Can we have last one question here? Last one question? Okay. Sorry.
Yes, last question, yeah.
Hi there. Yeah, with regards to the screening, I believe in what you just said because I fell into that situation. I was always told, because I have RP, that I would eventually become blind. I did lose my eyesight. I did get glaucoma. And by the time I went in, it was way too late. Thank you.
Exactly. Yeah, no, thank you for that comment. And so that's exactly the type of scenario that we'd like to address by doing this type of study, to really provide kind of concrete data on how many people there are out in the community like yourself who have either glaucoma or RP, to provide that as a strong rationale for the government to endorse, ocular screening exams. Thank you so much.
Thank you very much, Dr. Popovic. Thank you for all your presentations this morning and for all that you do. It's fantastic. Thank you. Just to answer your question there about myopia, to make a point, is a couple of years ago we did a study associated with the University of Waterloo School of Optometry in school kids, and found exactly that the level of myopia was very high. But the point I'd like to make there is that we found a correlation between the amount of time, an inverse correlation between the amount of time that kids spent outdoors to the myopia. So if you spent a little bit of time outdoors, there was a higher level of myopia, and if you spent a lot of time outdoors, your myopia was less. All this to say is encourage your kids to get out away from their screens, get outdoors, and there will be hopefully less myopia. Okay, we're going to break for lunch in a couple of minutes. Just ask you to, on your table, there's a sheet there that has 3 QR codes, and those will, if you take it and screen them at home, it enable you to access 3 reports that we'd like you to have a look at. The first is the Living with Vision Loss in Canada report, which you're going to hear about this afternoon. The second is the Vision Health Canada's preliminary submission to Health Canada for the purpose of developing a national strategy for Bill C-284, and you'll hear more about that this afternoon. And the third one was Vision Health Canada's meeting with Health Canada, discussing the vision loss community's priorities for Bill C-284. So if you're interested in digging more into what you're going to hear this afternoon, there it is in front of you.